Ladies and gentlemen, today it is my honor to participate the conference and have a chance to talk about the important topic, Choosing Wisely campaign, a medical reflection in the new century. Choosing wisely is not equal to shared decision making. Shared decision making is a procedure to apply evidence. But choosing wisely is a reflection of the medical care to enhance us to avoid low-value practice. Therefore, it belongs to audit. To start my talking, I just want to ask a question first. Is prevention really better than treatment? For example, do a man need to examine his testes during showering for early detection of testicular cancer? In the guideline of U.S. Preventive Service Task Force, it recommends that screening of testicular cancer is a grade D procedure. That means it may be harmful for well-being. The other famous example of overdiagnosis is about thyroid cancer screening. In Korea, there is a dramatic increasing of thyroid cancer incidence due to annual body health check. Unfortunately, there are no difference of thyroid cancer mortality even though the early detection rate is increased. In reality, because thyroid cancer is a relatively benign cancer, early detection of thyroid cancer did not lead to quality adjusted life year quality gain. That means thyroid cancer screening do not gain quality between treatment or not. In contrast, thyroid cancer screening led more thyroid surgeries and therefore increased the incidence of scarring and nerve injury. In 2014, Korea Physician Coalition called to stop screening, and finally the number of thyroid screening dropped down. This event has been published in NEJM in 2015. We can divide different cancers as different types of animal. Cancer of bird means a cancer goes up rapidly and with a poor prognosis. Snail cancer means a cancer goes up slowly and with a good prognosis. Cancer screening is more preferred to detect cancer of beer, just like colonoscopy for colon cancer. However, thyroid cancer is definitely belongs to the snail cancer, so that screening of thyroid cancer indicates an overdiagnosis. We can conclude that, screening or not, there should be based on the incidence and severity of the disease, your personal risk, the detection rate of screening tools, the next step after suspicious, the cause, and any quality gain for this screening. Because overdiagnosis and overtreatment become more serious worldwide. About 10 years ago, many affiliations announced that less is more to avoid lower value practice. In BMJ, they caused these issues as too much medicine, and less is more in drama, and right care in Lancet series. And some institutes call it do no harm. And finally, choosing wisely is the most accepted term because it can be avoid legal problem. But actually, my own opinion is the term choosing wisely is the most easy and misunderstood term for announcing this issue. Avoid low value practice. In Chinese translation, 明智选择 is more popular than the term 聪明就医, because choosing wisely is definitely a core of less is more, not the meaning of choosing carefully. Choosing wisely was launched in 2012 by American Board of Internal Medicine Foundation, ABIM. At first, they request each professional societies to point out 5 to 10 things that are low-value practice in their field. Finally, this call became a worldwide campaign. Many countries such as Brazil, Japan, Canada, Australia, Italy, and UK developed their own Choosing Wisely Association. In Taiwan Association of Hospital Medicine and Ka-Wai Taiwan are the first two organizations to promote the concept of choosing wisely. Ka-Wai Taiwan has pointed out that the most 5 low-value items in Taiwan and hope us to emphasize this issue. Finally, there are 80 societies and 510 things response to ABIM. Some low-value practice have been mentioned in several societies, such as PSA screening for old men with low risk of cancer have been mentioned in 5 societies, and brain CT for patients with syncope in 3 societies. Blood transfusion in patients with hemoglobin over 8 grams have mentioned in 5 societies, and preoperative chest X-ray in patients with no history of cardiac problem have been mentioned in 4 societies. The most things announced by the professional societies are overdiagnosis and overtreatment, and some focus on underuse and malpractice. Here are an examples on underuse and malpractice. Occasionally, some item may be uncertain, just like the benefit of zooming in on duration of breastfeeding may be challenged by new evidence. Now, you can find the recommendation in the Choosing Wisely website. The surgeon strategy can be via clinician list, or from the patient resource. The recommendation of screening will be approached in a very easy way. Sometimes, procedures have been abandoned in Western countries, but still common in Eastern region. For example, bed rest 6 to 8 hours after lumbar puncture are still implicated in many Eastern countries. Therefore, you will not find this item in the recommendation list. So, if your institute or hospital agree and want to promote choosing wisely, you can propose some topics first. You can determine the topics from the list of recommendation or not from the list. Moreover, some topics are belong to national level and some are belong to a hospital level. In my hospital, we started our Choosing Wisely action since 2019. We highlight 10 items. Most recommendations are highlighted in recommendation list. 2 are common low-value practice in Taiwan and also in my hospital. They are: do not use sliding scale alone to control blood sugar, and do not mandatory 8-hour bed rest in patients with lumbar puncture. And so, how to successfully avoid low-value care? There are three ways: limit, length, or listen. First, if the practice is belong to ineffective care, your hospital can inhibit this care by limitation of the order. Second, if the practice are belong to inefficient care, the action may through land method. Finally, if the low-value care are belong to unwanted care, for example, NG feeding for terminal patients, you can use shared decision-making to make consensus with the patient and family. How about the difficulty in applying choosing wisely? My answer is sometimes it's very easy, but sometimes are very difficult. For example, although I am a surgeon, many evidence show that limit the patient to shouldering is not necessary. In Western, early shouldering after surgery is a normal practice. But in Taiwan, even though in my department, my staff still have no confidence to abandon this practice. Generally, healthcare givers like to add rather than to minus. For example, if we only want a cup of clean water, but we add some salt first, we would like to add sugar to neutralize the salty, but not to remove the salt. Remember, shared decision-making is not equal to choosing wisely, but shared decision-making is one of the strategies to reduce low-value practice. Many factors influence the willingness to practice choosing wisely. Some are afraid of reducing their benefit, but some are afraid of legal problem. Some underestimate the harm to the patient. Some because of their paranoia. Sometimes the culture are not easy to shift, and many reasons are due to no action. Here, I want to share the outcome of choosing wisely action in my hospital. Some topics are very success. We reduce brain CT for about 80% in our emergency room. Reapply shared decision making and successfully reduce the number of NG feeding for terminal patients. But we are also disappointed for the topic on PSA screening. We cannot reduce the screening number due to the resistance of the urologist. How to evaluate the efficacy of choosing wisely? If the low-value care is assessed as inefficacy and needed to limit it, then you should follow the achievement rate. If the low-value practice is assessed as inefficient, then you can follow the reduction rate and the executive rate. Sometimes you can propose the performance indicators, like reducing how much clinical outcomes, or improve how much decisional confidence, or reducing how much cost. Now, we keep continuous monitor the indicator. We also add more topics in recent years, including eliminating CKMB testing in suspected acute coronary syndrome, reduce the daily chest rate in ICU, and reduce the unnecessary coagulation tests in emergency department. Here I conclude the successful keys in choosing wisely practice include policy promotion by government, health insurance limitation, leading by the medical center, promote quality improvement project, introduction to the medical education, intervention of professional societies, modify clinical practice guidelines, changing wrong culture, promotion by media, and abundant benefit from low-value practice. In conclusion, choosing wisely is a medical reflection of a healthcare giver, including physician, nursing, and pharmacy, etc. It is not equal to shared decision making. It needs all of us to make effort to avoid low-value practice and do no harm to the patient. Thank you for your attention.